Hello. We at Quality Insights are excited to bring you a quarterly recorded conversation series with residents and family members to assist you in quality improvement. For our second installment in this United We Stand series, I would like to introduce Quality Insights Project Coordinator from West Virginia, Sheila Barnett.
Thank you, Krista. My name is Sheila Barnett, and in today's broadcast, we are focusing on person-centered care and resident and family involvement with the interdisciplinary team. I'm with Pam Metter, who also is an RN with Quality Insights, but also has been a long-term care nurse for approximately 25 years. Just recently, she had a change in her role and went from being a professional on the interdisciplinary team to a resident representative. Pam, would you care to share your story with us and how we can have a better understanding of how facilities can make the resident the center of their interdisciplinary team?
Thanks, Sheila. As Sheila said, my name is Pam Metter, and I have been a nurse in long-term care for many, many years. I've enjoyed many roles in the long-term care environment, from floor nurse all the way to director of nursing. A few years back, I had a close family member who came to me and asked if I would consider being her medical power of attorney. I agreed, so she wrote her wishes within her living will. She was fairly young and in good health at the time and required no assistance over the next few years. A few months ago, however, this family member, and I'll call her Cleo, had a stroke, and unfortunately she was in the hospital with all the classic stroke symptoms for a couple of weeks. The stroke affected her hearing, her speech, and her mobility significantly. She was ultimately discharged from the hospital to a skilled nursing facility to focus on rehabilitation. When she was first admitted to the facility, the residual effects of the stroke would give you the impression that her mental capacity was also diminished. When anyone asked her a question, she would smile and she would shrug, sometimes nodding her head. Many times this was understood to be affirmation of whatever the question was, or even an inability to answer the question. Soon, though, it was found that after she smiled and shrugged, if you gave her a bit of time, she would be able to answer with her true thoughts and wishes. She had a delayed response to communication due to her hearing loss and some aphasia, but given time to process the information, her communication was appropriate and it displayed orientation ×3. I would like to fast forward now to the first care conference. We had the entire interdisciplinary team at the table, which included, of course, me and Cleo. The care conference was going fabulous. We were discussing all the items we needed to discuss in order to ensure that Cleo was getting optimal, advanced, evidence-based quality of care. However, during this conversation, I noticed that Cleo had not said one word. She was just looking around, looking at her hands, just basically looking around the room. This had a huge impact on me. I was working from a healthcare professional approach as opposed to the resident representative approach that my role required. I realized to be a true resident representative, I needed to make sure she was the center of this conference, not all the approaches and the interventions and the plans we were discussing. I needed to make sure her voice was heard, not mine. Not the other professionals at the table, but her voice. We had the professional knowledge, but she had the intimate, personal wants, needs, and desires that we needed in order to make this her plan of care, and we were not tapping into that knowledge. So at that time, we regrouped and physically moved the members of the interdisciplinary team to where we were all addressing Cleo. We made sure she could hear us and that we could hear her. All questions and suggestions, thoughts and ideas were all directed to Cleo, and her answers, her concerns, her ideas, her requests, those were the center of our process. There were several things we found out that we were totally off base on. I'll share a couple of those examples with you. One example revolved around her intake. Her eating had diminished completely, and this, of course, led to weight loss and weakness and totally affected her progress in therapy. So we were discussing appetite stimulants and restorative dining, all these wonderful interventions we could use in order to get her eating again. Once we did what we should have done from the beginning, which was involve the resident in the conversation, we basically and directly asked her, why are you not eating and what can be done to help you eat? First, she said she just had no appetite, and there was so much food it turned her off eating. Based on that, the team discussed with Cleo if she would prefer 6 small meals instead of 3 large ones. Cleo agreed to this, and her team decided to try this for 3 days. They did this, but her intake did not improve significantly. And on a side note, from the QIO perspective, this is an example of using QAPI and small tests of change to help solve issues. They didn't make this change permanent. They made it temporary to see if it would help. Once they found out it did not work, they went back to the 3 meals per day for Cleo. The QIO can help you learn how to master these techniques to help you in finding the right approach and solving the problems effectively. All right, now back to Cleo. Since the 6 small meals were not effective, they went back to their list of suggestions and ideas and found that one of the things she said struck the team as peculiar. She stated she didn't have her sugar. We weren't sure exactly what that meant, so we probed a little bit deeper and found that her ability to taste had been diminished for quite some time, even before the stroke. So even at home, she would sprinkle sugar on everything she ate. This explained that this sugar would make the food less bland, and she began adding a sprinkle of sugar to everything she ate, green beans, meatloaves, salads, everything, and this would enhance the flavor and food appeal. Once this information was gathered, the team decided, with Cleo, that they would again use the QAPI approach and the PDSA, which is Plan, Do, Study, Act format, of testing this approach for a few days. They decided for 3 days they would place sugar packets on her tray for every meal so she could apply as much or as little sugar to her food in order to increase her intake. Lo and behold, her intake improved and greatly with that one intervention. By listening to her and following up on the things she said would work, we were able to develop a plan of care that worked for her. She was more accepting of the plan and worked with the team because it was her plan. She was involved in making it. Once her nutrition improved, she did better in therapy, she increased her independence and her mobility, and she is right now planning her discharge back home. This has taught the team members that the resident should be the first source of information, even if they have confusion when it comes to planning care. They have learned that who has the answers to the problems if not the resident? And the lesson I learned was that even after 25 years of thinking that I was providing true patient-centered care and putting the resident's best interests at heart, I still have a lot to learn. Being on this side of the table has given me an entirely new perspective. Our professional opinions are important, but they are just that. They are opinions. No matter how evidence-based they are, if the resident does not share that opinion, we must take that into consideration because we are impacting another person's life, a life they are in control of, even in the long-term care settings.
Thank you, Pam. It sounds like you have had some true insight on person-centered care from this experience. You mentioned that even confused residents should be involved in the care planning process. Could you please elaborate on how to accomplish this?
Sure. If you have a confused resident, you still bring them into the care conference. It makes it more difficult to find out their personal thoughts, but you still ask them the questions you're needing answered in order to provide care. Even in their confusion, they may give you clues to the answers that you would otherwise not expect. Many times this will make your job so much easier by taking the guessing game out of the situation. You're not just throwing approaches at the problem and hoping it works, but you're doing everything you can to get to the root cause of the problem and fixing it. One approach we like to use is the 5 magic questions. Basically, it's taking the 5 senses and using them as a guide to find out resident preferences. For example, if you have a resident who is not sleeping, during the care conference where the resident and the family are working with you, begin by asking them, before you went to bed at night, what would you like to see? What would you like to feel at bedtime? What would you like to taste at bedtime? What did you like to hear at bedtime? And what would you like to smell at bedtime? And some of those answers could be things like, I always had to have a glass of milk before I went to bed. That would relax me, or it would relax Mom to have a cup of chamomile tea before bedtime. Or they might say she could never sleep on anything except flannel sheets. Flannel sheets was the only thing she could ever sleep on. And you can get ideas as to some interventions you could try. Another example is like a fan at night. What did they like to hear? Mom couldn't sleep without a fan on. And those are the things that you would try to help this resident to go to bed and sleep at night. And you would want to do quick tests of change to see which ones of those interventions would help this resident go to bed. The trick is to involve those who know the answers, and that would be the resident and the family.
Those are some great tips on how to increase the person-centered focus in a facility. For more information on how to use the QAPI Foundation or any other tips heard in this broadcast, please contact your state's project coordinator listed on this slide. Thank you very much and have a wonderful day.